Okay, welcome to part 2 of the day 2 lecture on opioids and addiction. Let's try to understand why opioids are addictive from the physiological level. The short answer is going to be dopamine release in the nucleus accumbens, but this is going to be through a different mechanism than cocaine or methamphetamines, which directly increase dopamine in the synapse. Here, the effect is going to be indirect by acting on inhibitory interneurons. We're going to inhibit the inhibition. So let's take a look at how that works. So on this slide, we're going to focus on the diagram on the bottom left-hand side. You can see there's a beta endorphin opioid neuron synapsing on a GABAergic neuron in the ventral tegmental area. Now remember, GABA is inhibitory, and you can see the beta endorphin neuron is inhibiting the GABA neuron. So it's inhibiting the inhibition of that mesolimbic cell. So that's exciting the mesolimbic cell, making it more likely to fire and synapsing on a dopamine neuron in the nucleus accumbens, thereby increasing the amount of dopamine. So mu opioid agonists increase dopaminergic neuron firing. Dopamine is a neuromodulator that can change the way other neurons fire. So dopamine triggers learning through changing things like the density of receptors on the postsynaptic neuron. You can see in the picture on the left-hand side, there's only a few receptors, but on the right-hand side, the density has increased, or it could change the amount of vesicles or amount of neurotransmitter inside of vesicles in the presynaptic neuron. Or there are several other mechanisms by which learning can occur at the synapse level. And so this can be a major component of addiction as the release of dopamine is associated with those drug cues as you administer the drug, such as the needle that you use or the people that you're around when you administer the drug. So remember, we have 4 different types of endogenous opioid receptors and opioid-producing neurons, and not all of them are going to have the same effect on dopamine. So the kappa agonists are actually going to reduce dopaminergic activity. Here we're looking at the middle panel, and you can see we have dynorphin, it's one of our endogenous opioid, is synapsing on the mesolimbic cell, which in turn synapses in the nucleus accumbens. So instead of inhibiting the inhibition, now we're directly inhibiting that mesolimbic cell and preventing the release of dopamine. And this can explain why kappa activation is going to be aversive and not addictive. And it explains some of the unpleasant and emotional aspects of withdrawal from opioids. We've talked about tolerance and withdrawal in previous lectures, but we should talk about it again for opioids as well. So remember, tolerance is the diminishing effect of a drug with repeated use due to sensitization and learning. And something interesting can happen with opioids where we get a cross tolerance. So when you take one opioid drug, it can make you less responsive to a different opioid drug. For example, heroin users, when prescribed codeine, will have to take a larger dose to get the same therapeutic effect. Or in the case of methadone, which is used in dependence and opioid maintenance therapy, methadone can make heroin users respond less positively to the drug and remove some of the rewarding behaviors with the drug. But tolerance is not all just physiological changes at the synapse, but there's learning involved that with repeated administration of the same drug, you psychologically become prepared for that drug based on your surroundings. So this is a really important thing to know, that you can take the same dose in a different environment and it can result in an overdose if you're not in the same safe and familiar environment that you usually administer the drug. We'll take a closer look at that in a second. So remember that that metabotropic G protein receptors are slow, and that they require second messengers to create a signaling cascade. So in the case of opioid tolerance, you can have receptor desensitization, and that's a failure of the receptors to respond to the drug for long-term binding, and that's due to a conformational change in that G protein, where the receptor actually becomes decoupled from the G protein, as you can see on the right-hand figure. And it's not until that full signaling cascade is complete that the receptors are returned to the membrane and resensitized for further opioid binding. So you might be wondering why we're not addicted to our own endogenous opioids. After all, we have opioid-producing neurons that are releasing opiates into the system. But they're released intermittently and they're metabolized quickly, and so they don't survive very long on the receptor. And so the receptors are constantly being refreshed and resensitized for further binding. And that's in contrast to exogenous opioids, which are going to linger for a longer time in the receptor and interfere with the recycling and resensitization. As I mentioned a minute ago, it's not just physiological changes at the synapse. There's also a learning and psychological component to tolerance and addiction. And so there's environmental cues. If you typically take your drug in the same place each time, you'll learn those cues and you'll go through some physiological changes in preparation for the drug. So overdose, in many cases, in those novel environments, may be a failure of tolerance and the lack of that preparation in the novel environment. So there was an experiment all the way back in 1982 looking at mortality in rats after a heroin injection using a constant dose in either the same or different environments that they were used to. And on test day, rats either received heroin in the same location that they were trained when they first experienced the drug, or they received the same amount of heroin at a novel location with the same amount of drug. In the control condition, they just administered heroin one time on the testing day. And you can see in the table 1 the results. The mortality for the rats in the novel environment was more than twice that of the rats in the standard environment that they were familiar with. And in the control condition, where rats were receiving heroin for the first time, mortality was very high. So there was no tolerance in the control condition, some tolerance in the novel condition, but not nearly as much as rats in the familiar environment, showing a strong learning and learning component. So let's say there's a drug addict who wants to get sober, and so they take their last dose. And we're looking at the right-hand side of the figure. What does the opioid withdrawal timeline look like? So starting from the very left-hand side, at the last dose, 72 hours from that point, the person will experience the peak physical symptoms. And I mentioned these last time, where they're flu-like symptoms like chills and fever, body aches, and those rebound symptoms that are kind of opposite of what you get when you administer the opioid, such as diarrhea and pain and nausea. A week after the last dose, the physical symptoms will start to lessen. You'll have just mild sweating, body aches, anxiety, and irritability. And then 2 weeks from then, you should have you should experience the peak psychological and emotional symptoms like depression, anxiety, and irritability. Um, and even a month later, you'll still have cravings and depression, and that can last for weeks or months. And again, these are rebound symptoms of withdrawal, right? The opioid action is opposite of that of the withdrawal symptom. So analgesia leads after opioid withdrawal leads to pain, irritability, and hyperanalgesia or increased pain. Respiratory depression becomes rapid breathing. Euphoria becomes depression. Relaxation becomes agitation. Constipation becomes diarrhea. Pupil constriction becomes dilation. Right? So these are all rebound symptoms, and make sure that you're familiar with the opioid action as well as the rebound withdrawal symptom. So now let's take a look at some of the physiological mechanisms of withdrawal. And in particular, we're going to focus on the locus coeruleus and the periaqueductal gray matter. And if we inject opioid antagonists into either of these regions, a rat will immediately go into withdrawal. And this is a rebound effect because the locus coeruleus is involved in arousal and vigilance and anxiety and panic. So when you stop taking an opioid or when you introduce an opioid antagonist in an addict, the suppression of the locus coeruleus will be removed, and it's going to rebound, resulting in increased anxiety and stress. And also, as I mentioned earlier, the kappa opioid receptors are going to have the opposite effect of the mu opioid receptors on dopamine release. So kappa decreases the amount of dopamine release, and that's going to create negative feelings of withdrawal. So I talked about Pavlovian conditioning on a previous slide regarding opioid use and potential overdose in a novel environment. So let's take a closer look at Pavlovian conditioning. You're probably familiar with it from your Psych 151 or 101. Before conditioning, we'll start with some unconditioned stimulus like food, and we'll have some unconditioned response like salivation. So when the dog sees the food, it salivates in anticipation of getting the treat. Again, before conditioning, we introduce a neutral stimulus, and the dog will have no response. So it's not going to respond to the bell because it hasn't been paired with any unconditioned stimulus. But during conditioning, we'll pair the bell with the unconditioned stimulus, and the dog will have the unconditioned response, the salivation. So after a while, the bell and the food will be paired so that after conditioning, when the dog hears the bell, it has the conditioned response and salivates, even when no food is presented. So this is Pavlovian conditioning, that the dog learns the association between the unconditioned stimulus and the neutral stimulus and responds now to just the conditioned stimulus. So drug dependence is going to be related to negative reinforcement. So we'll break these down at positive and negative reinforcement. So reinforcement is when you become more likely to repeat a behavior after it's been reinforced. And so that can be positive or negative reinforcement, and that's going to be distinct from punishment. So let me explain. Positive reinforcement is when you introduce a reward for a behavior. So if you turn in your homework on time, you get praised by your teacher, and that should increase your likelihood to turn in your homework on time in the future. Negative reinforcement is not punishment. This is instead trying to reinforce a behavior by removing an unpleasant stimulus. So, for example, here we turn in our homework on time, and the teacher stops criticizing the late homework, so you become more likely to turn in your homework on time in the future. And so, drug dependence is closely related to negative reinforcement. Originally, when you're first starting to take the drug, you get positive reinforcement. You get a reward. It's a rewarding experience when you have your dopamine squirts of dopamine in the nucleus accumbens. You get that positive reinforcement. But once you build up some dependence on the drug, now the drug-seeking behavior is a way to escape the withdrawal symptoms, and so that's a negative reinforcement. It's relief from the withdrawal symptoms that's driving the drug-seeking behavior. So this is the two-stage theory of dependence. We're starting at stage one, the bottom left-hand part of your screen. You can see that this is like the positive reinforcement stage. This is where you have a craving, you take the drug, and you get a pleasurable effect. When you stop taking the drug, you don't really experience any withdrawal symptoms. However, when we move into stage two, it becomes dominated by a negative reinforcement. So when you take the drug in response to a craving and you get intoxicated, you'll have relief from withdrawal symptoms. However, when you have a protracted period of abstinence or you stop taking the drug, you'll experience negative affect and withdrawal. And your craving will be more related to seeking relief of the withdrawal symptoms than craving the reward of the drug. So stage one is sometimes called the impulsive stage, where your motivation is positive reinforcement or the rewarding effects of the drug. And that's dominated by the dopamine pathway from the ventral tegmental area to the nucleus accumbens. And stage two is the compulsive stage, where your motivation is negative reinforcement or with relief from withdrawal, and where you take the drug to avoid that negative persistent state. And this is going to be dominated by your norepinephrine system and your locus coeruleus, as well as your emotional limbic areas like the amygdala. And this is also going to be associated with more kappa activation during the withdrawal period.